So Crystal Oldman is the Chief Executive of the Queen's Nursing Institute, and I know there are some colleagues in this room that really would welcome the opportunity to have conversations around some of the challenges of working within community healthcare, and also some of the fantastic opportunities that are already existing and ahead of us. Kristen and I had a chat just before the day began, and we share that we both worked at UCH in central London at different times, and actually I've discovered that there's a small group that I want to know more about basically people around my age or slightly older who are involved in a charity. But Crystal has not only the Chief Executive of the Nursing Institute, she also works pretty locally. So the healthcare within Buckinghamshire matters to her. So she is the governing body nurse with Chiltern and Aylesbury, so it's now federated CCG. And also, Crystal has been doing some national work, which is going to be really important for us around, and I'm sorry, I keep gravitating over to the community side of the room. I do want you all to merge, please, in the break. But some really important work around really understanding our workforce outside the hospital setting, where we have just as complex and acute patients, and how do we make sure we have a workforce not just for the next year, but for the next 5 years, and how do we look at case mix and see that more or less visible stress and pressure around acuity dependency out in the community. So I will not talk anymore, and I will hand over to Crystal. Thank you.
Well, thank you so much. What a lovely warm welcome, and thank you so much for inviting me. As Carolyn said, I do sit on the governing body of Aylesbury and CCG, Aylesbury and Chiltern CCG, and I have a personal interest. I live in the area too, so I of course have a personal interest in the healthcare that's available. And what a joy it is to be here amongst so many of you who work not only in the hospital but also in the community. And what a fabulous opportunity it is to have a provider organisation that covers both the hospital and the community. So when Ian, who I can't spot now, but when Ian was talking about the opportunities, don't leave, we might be able to offer you something else. For those of you who are working in the hospital, think about the community. It's an amazing place to work. For those of you who are working in the community and think, oh, I don't know, I've had enough of this, I might want to work somewhere else, talk to your hospital colleagues. Maybe there's an opportunity in the hospital too. I think you have the most amazing opportunities here. And one of the other things that I've just heard and witnessed is the relationship between Neil and Carolyn. And all the evidence is of the most high-performing organisations is that where the relationship is great between the chief exec and the chief nurse or director of nursing, there is the opportunity for the best operating, the best performing organisations. So what an accolade that is to both of you to see that relationship and to see how you're working together. So on to my presentation, and what I wanted to talk to you about today was about leading change in nursing. And we're always hearing about this, aren't we? I've been in nursing. This year, it'll be 40 years since I started training, 1977 at UCH. And there's always change, though, isn't there? Since I started, always change in nursing, always change in the NHS. So it's something that we have to embrace, but let's enjoy it. Let's make the most of it. Let's make the most of the opportunities that there are that are facing you with those changes. And let's talk about how we manage some of those changes. So I've got some messages up on the slides this morning. The secret of change is to focus all of your energy, not on fighting the old, but building the new. So often we spend a lot of our time saying, yeah, but it was like that. Well, we tried that. We did that. That's what it was like. Or trying to hold on to something that's not really working. So it's great if we can embrace new, but there are some messages that I've got about how to embrace the new. Understanding, I think, why we need to change is really important. Anyone heard of the 5-year forward view? Not everybody. However, what I would say is, for those of you who haven't heard of the 5-year forward view, it is one of the best documents I have ever seen that's come out of, this is from NHS England, but it's one of the best documents I've seen coming out of a central organisation, easy to read, and it applies to all of you in the room, wherever you work. And it gives you that argument for change, why we've got to change, the older population, all the things that you know, and it gives you that direction of change, where we're heading and why we need to go that way. So I would really encourage you to have a look at that. There's a number of other policy documents there, but if you read one, read the 5-year forward view. There's also many, many changes in nurse education, as you'll be aware. And in my 40 years, I have never known so many changes in nurse education coming at once. We have nursing associates. Are you embracing nursing associates locally?
We are.
You are?
We're one of our fast followers, or we're wanting to be fast leaders. But yeah.
Fantastic. That's really good. Being a part of it, being a part of the change, really important. The funding for pre-reg nurses. So nurses are now going to be paying their own fees, and we are yet to see how that's going to pan out and whether we're going to see the same level of applicants. Changes in funding to post-qualifying, and for all of you in the room who are qualified nurses, many of you will have been able to have your post-qualifying courses funded. That's not going to be quite the same in the future. The apprenticeship model too for specialist practice, for example, district nursing, that's going to change too. This will be the last year that HEE will be funding specialist practice. And so we need to focus on ensuring that our students get the best possible experience when they're out in the hospital and out in the community with you. Because just as Ian said, you want the nurses who come and have the experience with you to have the best possible time so they come and work with you. But we have to develop placements that are in places where perhaps they don't exist now, which includes general practice nursing. Huge shortage of general practice nurses right now. I know that you've got Mark Radford speaking with you this afternoon about the new framework for nursing that our Chief Nursing Officer in England, Jane Cummings, published last year. And within that, there's a highlight around unwarranted variation. And again, why do we need to change? There will be some waste in the system. Every one of you here could think of something now where you think, actually, we don't really need to do that, but we've always done it that way, and I can think of how to do it differently that would save some money or would save some time, which equals money and resource. And value. How do we know what value we bring? Really, really important to be able to demonstrate the value of nursing. I'll say a little bit more about that in a minute. One of the things that we do need to be able to demonstrate in our value, we need to be able to articulate it through data. Really important. So how can you promote any changes to a nursing service effectively? Only if you have the data. That doesn't necessarily mean hard data, as in figures. It also means the soft data too. The data around your patient stories. The data that you collect from your colleagues as well about what's happening in your service. But it's really, really important that we have the data, because in making a change, you need to know where you're starting from with the data and what you're trying to measure afterwards, having made that change, to demonstrate you've made a difference. And in collecting any data to demonstrate change and the outcomes of the change that you're making, we need the evidence of patient outcomes. Carolyn mentioned that I'm chairing the work stream at NHS Improvement on safe staffing in the district nursing service. I've been doing that over the last year, and the publication will be out for public engagement in the next couple of months, in February in fact. One of the most important people sitting around our table, the most important person sitting around our table, in fact, was our patient representative, and his view of what safe staffing meant for him in his life. And what we have put into our draft resource, which I hope you'll be able to see next month, is a quote directly from him. It was what mattered to him that was so important for us and guided us in the work that we did on that work stream. So sometimes, and many of you will have heard this, it's not, from the patient's perspective, it's not what is the matter with them, but what matters to them in terms of their outcomes. What do they want? What is it that they're asking you for? It might not quite be the same as what we as clinicians think should be an outcome. So what does all this mean for leadership? And why might you have become a leader if you are a leader, or might be thinking about it? I did some, my doctorate was all around leadership, and this is one of the quotes from somebody who was a leader. I decided I'd rather go for it that was the leadership post, than be managed by the person who would have got it if I hadn't. Some of you might recognise that kind of quote, and I think that too often that happens. So why do people become leaders? Well, that's one reason. What I'd like you to do, just indulge me for a moment, think of somebody who in your experience during your nursing career has been a fabulous leader for you. And Carolyn identified somebody that she experienced on a surgical ward, a surgical sister. So just for a moment, have that person in your mind when I go through a few qualities of fabulous leaders. See how they compare. So leadership is the capacity to translate vision into reality. Did they have a great vision? I can see from what's been the 3 speakers so far this morning, there's a great vision here in BHT. So did that leader have a great vision? And were they able to translate it for you into reality, into what it really meant for you and your job? Or was it a bit like the blind leading the blind? Not everybody, and there's lots of leaders who can have a great vision, but they don't necessarily translate it into your reality. Did that leader know who they were? Did they understand themselves and their qualities? What I found in the research that I undertook is what mattered greatly is how leaders saw themselves. Did they have integrity? So integrity is doing the right thing every time, even when no one's watching. So was that person full of integrity? Another great quality of a good leader. And communication has already been identified by Ian as really important. The single biggest problem in communication is the illusion it's taken place. A leader who thinks that they've communicated because they put a memo out on email, but haven't actually spoken, communicated and listened to the people that they're managing. Really important. Is the leader you're thinking of, did they have these qualities? Emotional intelligence. Really important. One of the things that has been identified as critical in nursing, and that nurses do have really good emotional intelligence. So it's not just about your IQ, it's also about your emotional intelligence and what you are able to, in terms of your communication, your relationships with people, and your understanding of others as a leader. Being able to put yourselves in other people's shoes, being able to pick up, as Ian said, when things aren't quite right with somebody, when they perhaps are thinking about leaving, and knowing then what to do with it. And in terms of that integrity, living in such a way that if someone spoke badly of you, no one would believe it, because you are always professional as that leader. And that nobody would think, if anyone said something bad, that's not you, that's not how you live your life and your professional and your personal life. And is that leader that you're thinking of, they're a great role model for you? Are you aspiring to be like them? Like Carolyn, I remember a great role model for me was a manager in the community. When I was working in the community, my very first job, I had a fantastic manager. She was all of those things that we've just spoken about. She had the vision, she could translate it, she listened, she communicated, and she shared her vision with us. She knew who we all were. She was able to bring us with her on that journey. And I actually didn't want to leave when I was working in that organisation because she was such a great person to work for. And a lot of the research has shown that people leave or move on to go and work with somebody. It's not necessarily actually the job that they're going for, it's the person that they're going to be working with, the reputation of the organisation they're going to be working with, and people stay because of the leader often as well. And I made a decision after 5 years, it really was time for me to move on. But I didn't really want to leave that leader because she was so great. But what I was able to take with me was all of the attributes, the learning that I had from her being such a great leader. And I had the most wonderful opportunity. I lost touch with her and had the most wonderful opportunity last year to meet with her again, quite by accident. And she was just as amazing as she was all of those 25 more years ago. So really important to have your role models and to think about all of those leadership qualities. I also think that leadership isn't for everybody. And that's quite controversial. You know, we're a bit hierarchical in nursing. We think that we should all be heading towards the top. But I don't necessarily think that that's the case. And I think there are some people who are more than happy not to be shoehorned into leadership positions. I know that not everybody agrees with me on that, but sometimes it's quite good to be controversial as well, and to say that not everybody is made to be a leader, but actually if everyone was a leader, who would be doing the work? That's also controversial, by the way, because leading is working. Sorry, Carolyn. And I also think, and this came out very strongly in my research, was around the support that you need as a leader, particularly as a new leader, but ongoing too. And that quite often what we do is say, you know what, you're a really good nurse. You can make a manager of nurses now. Bye. And that's it. Where's your support? Where's your development opportunity? We do the research that I did was in a university, in many universities actually, and what we did in universities as well, was to say, you're a great teacher. Now let me make you a head of department. No management, no leadership skills and development. You might show the potential, but it's really, really important that we have development opportunities to become the leader. It's not something that just is innate and happens. At the Q&I that I now lead, we recognise this in terms of the district nursing leadership role and how important that is. And we recognise that the programmes on which the district nursing programmes were, the standards on which they were being developed and delivered were very old. So we took a leadership position. We got all the right people around the table, NMC, RCN, all 4 countries, and we created voluntary standards for district nurse education and practice to build on the existing NMC standards. So sometimes you just have to do the right thing as well as a leader. And leaders come in all shapes and sizes and in all roles. Here is one of our Queen's nurses who's a nurse practitioner in primary care. You all have primary care colleagues and they're leading some fantastic work out in general practice. District nurses leading teams and leading care out in the community, the same as the sisters and charge nurses in the wards, leading teams of fantastic people, fantastic nurses, healthcare assistants, what will be nursing assistants, AHPs, etc. Nurses who are working, this is another nurse of ours who's working with homeless people. Nurses are doing wonderful work with the most vulnerable in our society, really leading the way with people who are homeless, asylum seekers, refugees, and so on. And innovating, doing things differently, leading change. And one of the signs of that good leader that you might still be thinking of is innovation. Did they want to do things differently? Did they think about innovation? Were they thinking about problem solving and the solutions? Not just sharing what the problems are, but actually how to create a solution as well. Which takes me back to the data and the importance of the data and knowing how to demonstrate your value as a nurse. So how do you promote the changes that you want to make in your nursing service effectively? If you want to make a change, if there's something you want to do in your area, how are you going to go about arguing your case, putting your case together for that change? One of the things that we did at the Q&I was to carry out a survey of general practice nurses. We knew there were some issues in general practice nursing. We knew that there were some things that needed to change in general practice nursing. So we created quite a lengthy survey, and we're delighted that nearly 3,500 practice nurses completed the survey. That was really quite something. It told us something, that they were committed enough to complete a survey, which was about 60 questions, so it must have taken them at least half an hour. But we were then able to create a report based on 3,500 voices about what was happening in primary care for nursing. And we were able to say and give the data that 34% of practice nurses were due to retire by 2020. That's really scary, isn't it? Those are your colleagues out there in general practice, and that will have an impact on your work. And that's part of us being a system together and thinking, well, how do we problem solve this? What's the solution then? And part of the solution is having great placements, of course, for students in primary care and recognising that this is a fantastic career opportunity and ensuring that there are opportunities for practice nurses, for nurses who want to go into practice nursing to be supported in making that change of their career. And that report has been hugely influential with NHS England, Public Health England and HEE. But it's really important when you make any changes to link to those outcomes and think again about that change that you want to make. If you were going to, you've all got an idea of what you would like to do differently in practice. If you're going to make that change, you're going to gather that data. What are the outcomes going to be? You know why you want to make that change, but how are you going to measure that you've actually made a difference? So part of why you want to change is because you want things to be better. You are going to be one of the top organisations in the UK. You are going to be one of those top providers. And all of you have got things that you want to change within your own practice. But you've got to know why you want to change it, where the data is, the argument to change, and what the outcomes are going to be if you make that change. What difference is it going to make to your patients, your families, the carers, your service? And really important, of course, to involve your patients in that and to be speaking to them. Now this might seem like quite a random slide, so I'm just going to say a couple of words about this. And Neil has already heard my story on this. We have a number of fellows at the QNI, and one of them is Chief Exec of a provider organisation, community provider organisation for mental health, learning disability and community services. And he said that he has started to change his language because he realised that the language of community wasn't talking to the language of our hospital-based colleagues. And so what he said was he started to describe his services as hospital beds, even though he doesn't use the word hospital, of course, because they're all out in the community. So what he said is, and I'm using the first stats are your stats, the first figure, that the local hospital, so if I'm sitting in the community and I'm in charge of the community services, I can say to my hospital colleagues, well, there are 722 beds in BHT. 66 of them are the regional specialist spinal. But actually in my district nursing service, I've made up this figure, 2,000 beds for people in their own homes. And in the residential care homes, I've got 2,400 beds. Many of the district nurses go into those, and so do the general practice nurses and the GPs. And in the nursing homes, I've got 600 beds. And the QNI who uses this said it changed the conversation. It changed the conversation because his hospital-based colleagues began to understand that the fuzzy world out there of community actually has numbers to it. So again, my emphasis is if you're going to change anything, it is helpful to have data, it is helpful to have the hard data and the qualitative data. But he has found that very powerful. So I have begun to promote this as an idea so that you're all talking the same language. So how many beds do you have? Or how many, if you're a health visitor, how many families do you have on your caseload? Very helpful. The other thing in terms of data is being able to collect data easily and the use of technology and how important that is. In 2012, we produced a report called Smart New World, and we're going to update that this year. We have done a survey already, we've collected the data around how technology is being used in the community, and the early signals are that 40% of nurses working in the community are still working on paper, which I thought was extraordinary, and that's not quite the image that we have right now of the use of technology. But again, we hope to use that data to be able to influence centrally the funding that goes into supporting the development of mobile working in the community. Some of you will be aware that we use data as well at the QNI for our discharge planning, our transfer of care report, and what a wonderful opportunity it is in a provider organisation that has community and the hospital to be able to have fantastic transfers of care. That should be one of the most wonderful things that you're able to do in a joined up provider. And just a last few messages about how you continue to learn as a leader and the networks that are important. Because I've talked about learning and development, developing of those skills as you've become a manager and a leader, but is actually keeping those up as well. And one of the most important things you can do is learn from others. We've been contacted a number of times by these countries about how community works in the UK, because we have a really good reputation internationally about our healthcare. Of course, the NHS is held up as being one of the best healthcare systems in the world. We've also putting our money where our mouth is and developing a leadership programme for our Queen's nurses as well. We have 1,100 Queen's nurses, and there's going to be an opportunity over the next couple of years for 40 of them to go through a leadership programme, because we really want to see those who have got that community experience getting into senior system and service leader jobs. So, and we have, some of you will know Sharon because she worked at the local university, and she's just been appointed with us. She started with us in October, and she's going to be leading a leadership programme. And our Queen's nurses, any Queen's nurses here today? Yay! If anyone wants to know, there are five Queen's nurses here. If anyone wants to know what Queen's nurse is, those ladies that just put their hands up, go talk to them. Our Queen's nurses are our ambassadors for best practice. I've got 3 minutes. Our ambassadors for best practice, and they are our eyes and ears on the ground, and they represent us often on advisory groups with the Department of Health, NHS England and so on. Fantastic as the role models for nursing. They have their own network. We bring them together once a year, and then we also give them an opportunity to share their experiences and their innovations at our annual meeting. We've also last year, created a Community Nurse Executive Network. We recognised that there was because we were listening to what the leaders were saying to us, we recognised that the senior leaders in the system, so the directors of nursing, chief nurses, associate assistant directors of nursing, were asking for their own network. So we created a network that's supported by ourselves that gives the opportunity for those directors of nursing to come together to talk about the issues like safe staffing, retention, recruitment, mobile working, the use of technology. They come together and share and learn from each other. So really helpful, and Carolyn belongs to that. We've been around for 130 years this year, and we really hope, on my watch, we must continue for another 130 years. So I just thank you very much for inviting me today to share with you some of my thoughts around leadership, some of them controversial, sorry about that. And I will be around for part of the day if anyone's got any questions. Thank you very much.